Alright, so before we go into our next section, basically this table covers like 4 or 5 different questions because it compares the pharmacokinetics of neonates, pregnancy, obesity, and elderly. There's also another two that should be discussed, which is liver disease and renal disease. So, I guess the way you should be able to classify is that you remember the things that are unique about neonates is that you have increased cardiac output and you have decreased fat and you have increased minute ventilation, you have increased total body water. In pregnancy, you have the progesterone and estrogen, that's the most important, and so you have increased minute ventilation, reduced FRC. But you also have increased fat, you have increased total body water, okay, and increased cardiac output. In obesity, you have increased cardiac output, increased total body weight, and lean body mass. You have reduced FRC, and you have the cirrhosis one, and the only one with increased albumin. And then you have elderly. It's the only one with a reduced cardiac output and a reduced total body water. So those are the big factors. Now let's talk about oral. So in neonates, oral, you have decreased gastric emptying. And the reason is because the muscles are not contracting. You also have thin skin. In pregnancy, you have delayed gastric emptying, especially only in active labor. And then you also have nausea and vomiting. And you have more skin blood flow, so it's better for topical. In obesity, you have delayed gastric emptying. You also might have cirrhosis, which reduces first pass metabolism but increases oral bioavailability. Remember, they're always opposite. And the reason is because the liver doesn't metabolize, so you get more of the drug. And poor vascularity due to fat, so you get slower absorption. And then in elderly, you have a reduced GI transit, similar to the neonates in that it's not gastric empty, but it's a transit. And you have thin skin and absorption, again, similar to the neonates. Then for inhalation anesthetics, you have increased minute ventilation for neonates, increased minute ventilation for progesterone, for pregnancy, and increased minute ventilation for obesity, and they both have reduced FRC. So remember, the time constant is FRC over VA, right? So that means the time constant will be less if the top is reduced and the bottom is increased, and so you have a quicker onset. And you also have epidural vein engorgements in pregnancy. Then, in terms of distribution, we talked about this. Increased total body water means increased VD for hydrophilic, reduced fat, reduced VD. Now, pregnancy is increased TBW, increased fat, increased blood volume, and in obesity you have increased fat, which is 2/3, and increased lean body mass, which is 1/3, and it kind of increases total body weight and fat and lean body mass linearly, but after a plateau, after BMI of 40, it plateaus the lean body mass. And then total body weight in the elderly is reduced, but the fat is increased. Albumin, so in neonates you have reduced albumin, alpha-1 a alpha-1 glycoprotein, and you have more unbound drug, but also increased clearance. In pregnancy, you have decreased albumin, okay, decreased binding and increased clearance. In obesity, you have increased alpha-1 anti-glycoprotein, not only because you have increased fat, but it's also an acute phase reactant. So it's like an inflammation. And in elderly, you have reduced albumin and reduced oncotic pressure. So obviously, when you have reduced albumin, you have reduced oncotic pressure. And you get fluid overload, increased VD, and hydrophilic. So the only one with increased albumin or increased muscle basically is the obesity. Distribution, you have increased cardiac output in all of them except elderly, and that means that the blood will be diluted, so decreased peak concentration, but it will be a quicker time to peak effect. Then the other thing that's relevant is the blood pH. For pregnancy, you have respiratory alkalosis, so pH is up. So if you have acidic drugs, acids ionize above and unionized below. So if you have pH is up, they'll be ionized above. They can get acidic trapping, possible fetal iron trapping, but it's usually not clinically relevant. Then you have neonates. So you have metabolism. You have immature, phase 1 and phase 2 reduced, and that affects, what is it? Low HER drugs, example methadone. You also have decreased plasma cholinesterases. So I always forget that plasma cholinesterases is important in here. Then you have decreased sex metabolism. Now, in pregnancy, because of progesterone, it potentiates or induces, so increases metabolized, reduced free drugs, increases metabolism and metabolites. Estrogen inhibits the CYP450, so that's actually quite important. And the way you remember that is PP, so P potentiate, and then E inhibits. You also have increased renal blood flow, increased GFR, and clearance. The thing with neonates, even though you have increased cardiac output, you don't have an increase in GFR, despite increased cardiac output due to preferentiating uh, important organs. Then in obesity, you have increased renal elimination, you have increased tubal secretion and reduced reabsorption because you have an increased GFR. So you have, like, it's trying to get rid of it, and you have less going into the blood. And also with liver cirrhosis, you have reduced biome. Now with the obesity thing, with liver cirrhosis, you also talk about phase 1 and phase 2. However, in non-alcoholic fatty liver disease or cirrhosis, it can reduce, and HbF is increases with high clearance drugs. And then you have increased pseudocholinesterases. In pregnancy, you have reduced pseudocholinesterases. In elderly, you have reduced hepatic function, and I would assume that the pseudocholinesterases are reduced by them. So pseudocholinesterases does reduce because it's produced in the liver. So pseudocholinesterases is actually produced in the liver. That's something I didn't know. This is not clinically relevant, though, that it's reduced in elderly. Alright, the other stuff we have is reduced renal blood flow and excretion, increased renal elimination. We talked about that. And then the pharmacodynamics. So neonates, you have immature RESP centers, sedative sensitivity, immature neuromuscular junctions, which is important, and increased MAC. In pregnancy, you have increased MAC sensitivity, you have increased local anesthetic sensitivity, decreased neuraxal dose, both due to progesterone and increasing endorphins. In obesity, you don't actually have a PD effect. And then in elderly, you have respiratory, pharyngeal tone, CNS, you have reduced numbers and increased sensitivity. You have CVS, autonomic dysfunction, increased risk of hypertension, decreased sensitivity of beta agonists, that's really important, and polypharmacy, interactions with other drugs, CYP450 inducers, inhibitors, all that stuff. And we know that Tony Salib he's a squeezer. So what is he? He's an inducer or amiodarone, so that's phenytoin, while amiodarone is an inhibitor, and tolerance, where you can say reduced receptors, GI protein coupled receptor, whatever.